This is an 85-year-old female with class 3 angina on 3 antianginals. She was referred to me for a multivessel PCI of her right coronary and her left circumflex. As we often see, as has been reviewed already, women often have very tortuous arteries. It can be sometimes smaller. And this particular right coronary artery is both tortuous and calcified and has clear angiographic evidence of nodular disease. Unfortunately, a non-surgical backup site with no atherectomy tried to treat this patient with a 6 French radial system. I think not surprisingly, they were unable to cross the lesion. It was a failed PCI, at which point it was referred to us. We went into this a little bit more prepared and more armed for battle. We went 8 French femoral. There is some limited ability to get large bore devices into smaller women. That's one of the difficulties in treating them, and expecting we'd have a difficult time with delivery. We went with an 8 French femoral system, although I much prefer 7 French radial whenever possible in our chip cases. We used an AL 0.75. Not surprising, this is difficult to wire. I think the lesion was a little bit more beat up on from the prior angioplasty. It seemed tighter than it was on the referral initial films. Eventually, with some difficulty using a microcatheter into SU03, which is one of our CTO retrograde wires we like that works really well with tortuosity, we were able to course through the lesion. We swapped out for a rotational atherectomy burr because we didn't think we'd be able to get anything down unless we made a pilot hole. And after several runs of 1.5 rota, we were able to perform IVUS, which, not surprising with nodular disease. You can see that the rotational atherectomy had minimal benefit in terms of impacting this, probably because the wire bias in this case was not favorably slanted toward hitting this. And so with that in mind, we did several rounds of IVL. Having made a pilot hole with a guideliner, we were able to deliver the IVL device and IVL do this entire heavily calcified nodular segment. We placed overlapping DES after aggressive 1-to-1 predilation with the NC balloon. And you can see the final angiogram on the left and the final IVUS. I won't belabor this, but except to say we had about 80% stent expansion in the MSA part. And so it's a nice example of a hybrid strategy where a combination of atherectomy to make space, but the atherectomy device did not modify the nodule enough, and then following it up with IVL to really favorably impact the ability to get the stent expanded worked well. After this, we brought the patient back for a stage PCI. You can see this is her circumflex. Again, severe nodularity around the entire circumflex with a lot of tortuosity. In this particular example, given the tortuosity, I was not excited about using mechanical atherectomy. We hoped we'd be able to get this done with IVL alone. We're 7 French radial, 2 large nodules. Predilation balloons, not surprisingly, had a big divot in them. After predilation, we were able to deliver an OCT catheter to here. I couldn't get it readily around the bend. But you can see during the pullback here, we don't really need to look at the whole thing except to say that, again, there's substantial nodular calcium, which was not impacted at all with the predilation balloon. So 1-to-1 sized IVL, initially a divot, and after 80 pulses, you can see the IVL expansion is much, much better. We follow this up typically with something like an angiosculpt or another NC balloon to make sure the lesion is compliant and further try to prep it. And after that, we're able to place a single drug-eluting stent with guideliner-assisted delivery. And you can see the severe tortuosity we were dealing with in this example. After implantation and post-dilation of the stent, unfortunately, we couldn't get the OCT in any further. A lot of times when you place a stent in an artery like this, you make it less compliant, I should say, in terms of its ability to accept these monorail imaging catheters. We imaged the proximal portion, in which case we had, you can see here, a lot of stent under expansion and malapposition proximally osmally. We addressed this with further NC balloon dilation, and then this is the final angiogram. And so, nodular calcium is difficult. We see it more commonly in women, more commonly in the right coronary artery, although the circumflex in this particular example is quite challenging. And so I think, thinking about intravascular lithotripsy as a way to treat these patients more readily and more easily without having to deal with mechanical atherectomy, especially in tortuous segments, is something that we can look forward to as we get more data supporting use of this device in treating patients with nodular disease. There are certain mechanistic advantages to IVL in terms of its ability to fracture deep calcium, being independent of wire bias. We do see good MSA and stent expansion for IVL nodules, and at least the early outcomes look promising.